All right, listen up. Your mission, should you choose to accept it, is esophageal dysphagia. We are locking on high-yield targets for USMLE Step 2, PLAB, and TUS. Think of this whole thing as a complex plumbing problem. It's going to require some absolutely surgical logic to solve. Let's get to it.
Here's our operational plan. We've got 6 phases to execute to absolutely master this material. Every step is critical, so stay focused.
Okay, kicking things off with a rapid intel download. Time is of the essence, so try to keep up.
Now, the very first distinction you have to make comes straight from the patient's history. It's simple. If they have trouble swallowing both solids and liquids right from the get-go, you're thinking motility. The pump is basically dead. But if it's solids first and then liquids later on, that's a structural problem. The pipe is just too narrow. This is your first, and I mean most important decision point.
So let's talk about achalasia. It's not just one single thing, you know? We actually classify it into 3 types. For your exams, you really want to lock in on type 2. That's the classic one, with that high-pressure, pan-esophageal pressurization you see on the Manometry heat maps. That's your money shot right there.
And you have got to be on the lookout for pseudoachalasia. Seriously, this is a massive board trap. You see an older patient, they're losing weight fast, and the symptoms just scream achalasia. You have to suspect a tumor at the GE junction. Knowing this difference is absolutely mission-critical for your exams.
Okay, before we go any further, we need to cover a quick but non-negotiable safety protocol.
So here's the mandatory disclaimer. All this content is for your educational prep for your exams. It is absolutely not medical advice. For real-life clinical decisions, you always consult the official guidelines and, of course, a qualified specialist. Got it? Good.
All right, protocol handled. Now let's dive deep into a case study.
So here's the file. We've got a 70-year-old man. He's having trouble swallowing solids, but liquids are fine. And he's dropped 15 pounds in just 2 months. The intern on the case suggests a barium swallow, probably looking for that classic bird's beak sign. But tell me, is that really the best next step here? Look, in a patient this age with these symptoms, you have to be thinking about esophageal cancer. A barium swallow, yeah, it might show a rat tail sign, but you can't get a biopsy from a picture. That's why the hacker's logic, the smart logic, is to go straight for an upper endoscopy. You get to see what's going on, and you can grab a tissue sample. For the boards, this is always the next best step.
So let's make this a hard rule. Burn it into your memory. New onset dysphagia plus weight loss in an elderly patient equals endoscopy first, period. No exceptions.
Okay, time to talk about another sneaky board trap. I call this one the Achalasia imposter. Scleroderma can fool you because it also presents with dysphagia, but what's happening is totally different. Smooth muscle gets replaced by fibrosis, which leads to some really nasty GERD. The absolute key difference, the thing you have to remember, is the pressure. In scleroderma, the lower esophageal sphincter pressure is low. In achalasia, it's high. It's simple. In scleroderma, the door can't close. In achalasia, the door won't open.
And this brings us right back around to pseudoachalasia. If you get a patient over 60, the manometry looks exactly like achalasia, but the symptoms came on super fast and they've lost a ton of weight, you absolutely must rule out pseudoachalasia. It's almost always a tumor at the GE junction physically blocking the pipe and mimicking the whole thing.
Okay, let's lock and load this knowledge. Time for a lightning round review to seal the logic in place. You ready?
First up, trouble with solids and liquids right from day one?
That's motility. Think achalasia.
What's the gold standard test for diagnosing achalasia?
High-resolution manometry.
That's the one. All right, a few more high-yield hits. Scleroderma LES pressure? It's low, atonic. The classic sign for diffuse esophageal spasm? That's your corkscrew esophagus. And Zenker's diverticulum? It's hiding out in Killian's triangle, back in the posterior hypopharynx. With that, our logic is sealed.
Excellent work. We have neutralized the key concepts of esophageal dysphagia. Now it's time to acquire our next target.
This briefing on esophageal dysphagia is complete, but don't get comfortable. Our GI journey continues. We're heading deeper into the acid storm of the stomach, where a whole new set of challenges are waiting. To stay mission ready, your next directive is to engage with our explainer on the gastric refinery. We'll be covering Baird's surveillance, telling the difference between benign and malignant ulcers, and neutralizing the H. pylori threat. Mastering these topics is non-negotiable for your exams. You can find it in the G1.2 module. That is all.
Dismissed.